Assalamu alaikum. I have nothing to disclose. And after disclosure, I would like to thank the program coordinator and program directors and the organizer, and especially Health Asia. I second Dr. Sanaullah in congratulating and thanking the organizers for arranging this type of seminars for cardiac surgery and promotion of cardiac surgical events in our city. The introduction has already been given by Dr. Sanaullah. So the basic, these are ERAS is a bundled care, consists of multiple elements, and that favors smooth recovery after surgery. They make the surgical procedure smooth as far as the results are concerned. In cardiac surgery, although this is a difficult or challenging as compared to the general surgery, because as Dr. Mangi said, that this program started by some European surgeons in 1990s for colorectal surgery, and then it was introduced into the cardiac surgery late, as presented by my colleagues also. And because of the unique challenges in cardiac surgery, because of the patient's characteristics and the issue of cardiopulmonary bypass circuit during the operative procedure that deals with the change in the physiological process in the body. So these patients require additional components of their overall management. So the Society of ERAS then came up with guidelines in 2019, and recently with the Society of Thoracic Surgeons, a combined consensus statements has been reviewed in 2024, which has got several components, or they have divided these elements into several categories. Like there are some general elements like shared decision making, means involving the patient and family and friends to decide about the surgery, to inform them, and their engagement in the process of this pre-operative assessment, and then establishment of multidisciplinary team. The entire team was shown in previous presentation, that all the healthcare professionals, including surgeons, anesthetists, intensivists, physiotherapists, pharmacists, they all combine together to help people to progress toward the safe care in cardiac surgical era. And then this is also important that if you have implemented or you have some guidelines, protocols, so you have to follow those guidelines also. And it is also important to audit your data, that whether these protocols are followed, because the compliance is absolutely necessary. Then only you can have data to come with meaningful results, and then you can probably recommend their utilization and application in various centers. And then there are some pre-operative process, pre-operative screening and risk assessment. This has got an entire table which soon will show. Prehabilitation is just informing patient, increasing their exercise capacity. You just see in the video that was all prehabilitation, involving the patient, engaging the patient to probably expect the surgical procedure and what to do after the surgery. So they already knew that what to do. So, and then limiting nothing per oral, as you've seen that they were allowed to drink some carbohydrate-rich fluid before surgery. So these are the guidelines which probably took into consideration the risk stratification pre-operatively. You can use the STSS score or the Euro score, which are commonly used. Then there is a frailty assessment. Frailty assessment, that the patients who are very weak because of their muscle, less muscle power, so they can probably build up on that. Then there is a delirium risk factor. That also be taken into consideration. Hemoglobin A1C, like you have to optimize your patient or make your patient safe for surgical procedure or to improve the outcome. So you can improve their preoperatively glucose glycemic control, so that the results are better. And as Dr. Tariq wisely said, that these are for elective procedure, and there is no contraindication to emergency surgery. But whenever it comes to elective surgery, you always optimize preoperative every patient in terms of their nutritional status, in terms of their hemoglobin, in terms of their glycemic control. Then there are some intraoperative procedures. These are all elements which are reinforced as a recommendations in the consensus statements recently. There's use of transesophageal echography. So most of the advanced institution use transesophageal echography in all patients, but its role in coronary artery bypass grafting is limited. But in structural heart disease, you always, whenever there are valve repairs are done, its importance is very crucial. Then there is a role of protective lung ventilation. Protective lung ventilation means you have to ventilate to make the alveolar ventilation to an extent that according to that particular body weight, and apply a PEEP that the lung, the small alveoli remained open. Then use of ventilation on cardiopulmonary bypass. There is a controversy in the literature, because people have done research and then they found there is no difference. But those who conduct slow ventilation during cardiopulmonary bypass, they suggest that the alveolar ventilation helps post-operatively. But again, the more literature needs to be presented or carried out to substantial this evidence. Use of pulmonary artery catheter. This is a very guiding principle. Like you have to goal-directed volume management, you can take help from the pulmonary artery catheter. So again, it's on outcome. Sometimes these catheters and these lines may not have impact on the outcome of the patient, but they do help in optimizing their care. Then central nervous monitoring, post-operative nausea and vomiting, because these are very concerned, and patients remain and feel hurt when they continue to have post-operative nausea, vomiting. They don't feel well. So you have to make their experience better by taking care of these. Goal-directed perfusion, it means you have to provide perfusion the amount which is needed. Meaning the oxygen delivery has to be according to the body weight, according to the body surface area. Then there are post-operative procedure like post-operative extubation, which can be even intraoperative extubation. But these are already being studied as a fast-track extubation. AKI prevention and management, post-operative activity and external precautions. We'll see in recent that how external precautions have been changed into a rigid fixation, which helps in some patients to mobilize even early as far as their hand movements are concerned. Then there are some multi-phase processes. Multi-phase processes like goal-directed therapy, opiate sparing management, regional analgesia like epidural, but it's not practiced in every center, but these are part of the ERA's recommendation. Patient blood management is very important, because you have to screen these patients for anemia, and if they are anemic, then these need to be corrected to avoid blood transfusion. So there is a entire patient blood management program which consists of a team of hematologists who probably sees what are the causes of anemia and how can they improve the anemia pre-operatively, and how then there are other areas to cover is intraoperatively, how to perform surgery to conserve blood, like avoid hemodilution, like surgical hemostasis should be good. So there are so many things which can help to minimize the use of blood transfusion. Similarly, if patient has more than 7.5 of hemoglobin, sometimes they do not benefit from the blood transfusion, and which is an extra cost to the patient and extra risk to the patient by transfusing if it's not going to help them. Post-operative atrial fibrillation, already a lot said about it. Then this is again with the incidence of 30 to 40%. It's very high incidence, and then it leads to atrial fibrillation related cardiomyopathy, thrombosis, stroke, and then antiarrhythmic drugs. So there are suggestions like if they are at a higher risk of through this score, so they can be started immediately post-operatively on beta blocker, and if they are high risk, they can even given amiodarone as a precautionary drug to avoid atrial fibrillation. Similarly, as discussed, posterior pericardiotomy is a very good procedure and recently has been endorsed by a large randomized controlled trial that this helps not only atrial fibrillation, but it also decreases the chances of cardiac tamponade also. So it has benefited both ways. It has decreased the rate of atrial fibrillation, and it has avoided cardiac tamponade as well. Surgical site infection, this is already in practice. We do give antibiotic as timely, which is a standard of care, and quality forum endorses it is to be given within 1 hour of surgery, and then if repeated, if the surgery is prolonged. And then the things that we saw in the video, that something needs to be started even pre-operative, like cessation of smoking and alcohol, because these can lead to post-operative complications of pulmonary complications as well as infective complications. So there are other areas also, like clipping of the hair in the operating room immediately before the surgery can lead to decreased wound infection chance. And then the glucose control, as we discussed, this is an important, because the elevated glucose is related to deep external wound infection, which has itself its high mortality disease. Then there are, apart from these post-operative and intraoperative, there are some ungraded care elements like management of the catheters, chest tube, Foley catheter, and CVP lines. These needs to be removed as soon as possible, or as their function is over. Then avoid chronic opioid use. Then the future directions are taking the surgery towards another area like minimal invasive surgery, which is already being practiced. So most of the things are already in practice. Minimally invasive surgery, mini thoracotomies, mini sternotomies, robotic surgery, they all are associated with small incisions, and small incisions give less pain, less infection, and they allow patient to recover fast and resume their jobs at an earlier date. Although these guidelines, these multiple elements of the guidelines and recommendations are a consensus opinion, but at the same time they also give the freedom that these should not be the absolute things. If you see, if there is something in your clinical judgment, so you can deviate from these also. It's not any, obviously again in the favor of patient. So deviation from recommendation is again encouraged on patient preference, clinical status, and local expertise. And if the current literature warrants some new things, so you can deviate from these recommendations as well. To summarize this in this, these are the things that we should all look before operation, during operations, and post-operatively. And these are the things which are in 3Com, like alcohol and smoking cessation, hemoglobin A1C and nutritional correction, avoidance of prolonged fasting, patient engagement technology, prehabilitation, antifibrinolytics during surgery to avoid excessive bleeding, avoid hypothermia and hyperthermia simultaneously, infection reduction bundle as we discussed, and optimization of external closure. Then there are avoidance of hypothermia postoperatively, biomarkers of acute kidney injury. They are not measured everywhere, but at least what you can do good fluid management, and that can also help you. Chest drainage management and delirium screening based on the ICU protocol, they can be done. So there were some aspect of guidelines from 2019 that were not repeated in this, but I have already mentioned them. So these can be part of these recommendations as well. And one of the things that rigid external fixation, how it helps, people have tried to put these clips. And I was seeing the presentation by the surgeon who did that he said he can mobilize his patient earlier, and even they can drive earlier if they have got a external fixation with the orthopedic principle. So their movement of the sternum is less, and this is a rigid fixation, and patient can be mobilized earlier, and they can probably use their arms better as compared to the standard conventional wires. These are some experiences from US center. They have applied some of the elements, and they found that these helps in reducing the cost early, and they were able to make them go home early, decrease length of stay. Similarly, there was a experience from Canada also, and what they did, like how to implement these program, what they did, they took some previous patients from even before era of COVID, and they took prospective data for new patients and applied few components of these eras, and then they compared the two groups, and then they found that those in which they applied these eras, they did well post-operatively. Again, it requires its paradigm shift in cardiac surgery, because it's very difficult to have multidisciplinary people at one stage. Like Danish has asked, in some people, some hospitals you may not have all components of all these healthcare professionals, but at least the thing that they provide can be provided by the few people who are already taking care of these patients. So way forward is challenging. There is a much work to be done, but the things usually happens, as I said, most of the things are already being practiced. Minimally invasive surgery is already being practiced. Fast track extubations are already in practice. So they will come in our way in future. So these are the recent references which I use for taking out these guidelines and recommendations. This is a picture just to demonstrate that this building was under construction at one point in time. You can see a tall building, and over a period of time it just completed, and these ducks are looking at it and admiring this building. So these things will change, and only time will probably tell us that how we have to keep pace with the time so that we can make it happen. तो अल्लामा इकबाल का एक शेर है कि पैवस्ता रहे शजर से उम्मीदें बहार रख, तो हम ये अगर रखेंगे तो इस पे चलेगा. थैंक यू सो मच.